All right, welcome everyone. Well, good morning, good afternoon, or good evening to everyone joining us from around the world. On behalf of the Global Tracheostomy Collaborative, it's my absolute pleasure to welcome you to our first webinar of 2026. It is truly wonderful to see participants joining us from so many different regions. Thank you so much for typing in and where you're joining us from. Your global presence is what makes this community so special. Before we begin today's program, I would like to take a moment to recognize and sincerely thank Amy Freeman-Sanderson, who's here on the panel with us, for her outstanding service as chair of the Global Tracheostomy Collaborative Education Committee over the past 2 years. Amy has done a phenomenal job thoughtfully identifying expert speakers, curating timely and critical topics, and ensuring our webinar series continues to meet the evolving needs of our global tracheostomy community. So Amy, thank you for your leadership, your dedication, all that you've done to advance education through GTC. We are truly grateful. As we look ahead, 2026, I am delighted to welcome our new chair of the Education Committee, Michael O'Brien. You're going to hear from him in a little bit. Michael and I first connected at the 10th International Tracheostomy Symposium in Chicago last fall. And from the very beginning, it was clear how passionate he is about improving the quality of care and outcomes for our patients and individuals with tracheostomy and their family members. Michael is a respiratory therapist in complex medical care at University of Virginia Health in Virginia, in the United States. In his role at the UVA Health's Pediatric Home Ventilator Program, he educates caregivers on routine management and systematic troubleshooting of equipment. Michael is pursuing a PhD at Rush University. Michael, welcome, and thank you for stepping in into this role and for taking on the responsibility of leading the Education Committee and moderating these webinars as we build this strong foundation that Amy has created over the last couple of years. I'm also very pleased to welcome Sandy Foster, who will be joining the Education Committee leadership as the Vice Chair. She has been a longstanding and valued member of GTC community. She's a clinical nurse consultant with over 25 years of experience at Monash Health in Australia, and she brings extensive expertise in supporting children with complex medical needs. She currently serves as a pediatric tracheostomy and respiratory services clinical nurse consultant, and she's truly committed to strengthening continuity of care and improving outcomes for children with tracheostomies. So thank you, Sandy, as well, for agreeing to take on this role and for partnering with Michael in leading our educational efforts. So with that bit of introduction to our new leaders, I'm delighted to hand things over to Michael and Sandy to officially kick off our first GTC webinar of 2026. Michael, over to you.
Vinciya, thank you so much for that introduction. And Amy, thank you so much for setting me and Sandy up for success. Welcome everyone to the first webinar of the year, in which we'll be talking about optimizing respiratory health with long-term tracheostomy ventilation. Here, we're going to be talking about perspectives from clinicians and families on the topic. Your speakers for tonight are Natalie Napolitano, Lindsey, Katie, and Phillip. Natalie is a respiratory therapist, clinical scientist at the Respiratory Therapy Department at the Children's Hospital of Philadelphia, where she runs a bench lab and guides evidence-based practice and clinical research important to the science of respiratory care. She is active with the state and national respiratory therapy associations. Lindsey is a pediatric nurse scientist, a National Clinician Scholars Program postdoctoral fellow at the University of California, San Francisco. Her clinical experience and research focus on improving transition from hospital to home for children with medical complexities, with particular emphasis on children requiring tracheostomy and ventilation. Katherine Baldwin is a pediatric pulmonologist at the University of Virginia. She cares for patients with a with a wide variety of pediatric lung disorders and breathing-related issues from other medical conditions. She has a special interest in severe asthma and complex care, including patients with technology dependence, prematurity, and aerodigestive disorders. She is a passionate advocate for patients and families. Her research interests include caregiver education, clinical strategies for managing bronchopulmonary dysplasia, and translational work in severe asthma. Phillip is a high school biology and engineering teacher for 15 years, a husband, and a father of 3. He chose to step into medical and care role because of financial reasons, as well as modeling for his children that as a father and a parent, you do what's necessary for your family. Introductions out of the way, Natalie is going to get us started with our discussion.
Hello, everyone. Good afternoon, good evening, and good morning, depending on where you are around the world. To kick us off, I'm just going to start with a review of the American Thoracic Society guidelines for the care of infants and children with tracheostomies that was published in May last year. In 2000, ATS published a statement on the care of a child with a chronic tracheostomy tube. Now, this was a comprehensive review of essential equipment, caregiver competencies, and potential complications that could occur in the home. This was, however, a consensus-based document. It was not evidence-based and was really phrased more as an official statement from the organization than really structured as a clinical practice guideline. That's why our group got together to really have the aim to create a document that was more of an official clinical practice guideline that was formatted and structured in the methodology of clinical practice guidelines, and that could really then be used to standardize practice to improve clinical outcomes and identify disparities contributing to this very high-risk population. There are several identified gaps in the literature within our group for the care of the child with tracheostomies, spanning all levels of care, from how do we decide and have the conversations about tracheostomy, how do we then do post-op care, into stabilizing for home, starting home training, at what point do you do that, what type of training programs are people going through, and then that transition to home, and then all of the things of care once outpatient. There were so many questions and a lot of gaps. Unfortunately, as this being a brand new guideline, we were limited to having only 6 questions that we could look at to answer this first time around. So although as we're going through here, you'll wonder why we're all over the place and a little bit scattered on these questions, because we tried to cover the spectrum as to where the most important things lied, at least within our group. And then also we had a parent family caregiver panel that was a group as part of this. So we had a core group of clinicians from all disciplines working with children with tracheostomies, whether inpatient and outpatient, and doing that transition, as well as having parents and caregivers who have gone through the process as well, kind of guiding and giving input with each parts along the way. So we had to narrow it down to 6 questions. We're going to review these relatively quickly, although some of the other panelists will also be talking about some pieces of it in a little bit more detail. So hopefully all your questions are answered at the end from all of us. Our first question that we tackled was, should ethical principles be applied to conversations with families about tracheostomy tube placement for their infants and children? And this seems like a very strange question, and we did a lot of phrasing around wording it, but the main gestalt of this that we wanted to get to was making sure that there was equality for all families and that they were approached in the same way and given the same opportunities and the same options for care, which we oftentimes hear about in our discussions with just clinicians, will they'll say, well, I'm not sure that the family can handle this, or they don't have the support, so we shouldn't offer a tracheostomy. But it's really not for us to decide. And we can potentially, as we talk about in some of the other guidelines, need to not be as rigid in potentially our discharge and what we think discharge should be and what planning should be and what education should happen and how many providers should have and what the home should look like, and be able to help flex for the family for what really is going to work best for them. So we also went into applying all the ethical principles of beneficence, non-malfeasance, autonomy, and justice to really help guide these decisions, and that we really struggle sometimes when we have some competing ethical principles where we feel we're doing no harm by not offering, but then we're taking away autonomy. So we all agreed really wholeheartedly, including our family partners, that we should be in that situation always preferencing autonomy. And it's really the patient and family's decision if our patient is able to make that decision as to what care they receive. Our second question, really, should a standardized process for initial discharge be used for infants and children with tracheostomy tubes? And our recommendation here is that we suggest implementing a standardized discharge process to facilitate that safe transition from hospital to home for a child that's tracheostomy dependent. Whatever that standardized discharge process looks like for your region, for your hospital, but whatever it is, it should be the same for every patient leaving your hospital. We didn't make specific suggestions as to exactly what should be in that standardized process, because that may be different and we might need to change things around a little bit to make it work for some patients. As an example, one of ours is that there should always be 2 caregivers in the home that are fully trained. But that might not be possible, particularly for our single parent. So if we're making that as a mandate and a guideline, then we're already eliminating a group of our population. And there are times that we need to be flexible for that and make them these guidelines to be more of an 80-20 rule. Most of the time, we'll start there and we'll start having that conversation, but we need to be able to flex to support the needs of the family. Our third question was, should infants and children with tracheostomies always have an awake and attentive trained caregiver present? This was a very long, probably the question that we had the most conversation about. And in the end, we recommended that an awake and alert trained caregiver should always be present with the child at risk of immediate decompensation due to tracheostomy-related complications. Most of us have seen enough very significant events that have occurred when somebody wasn't trained, that was present, awake and alert. So for that, knowing that these things could be avoided if someone awake and alert was there, we erred on the side of caution here in making this recommendation. But we did talk and make suggestions that we can make some changes to what trained caregiver means. One of the things that we've done with our population here at CHOP, where we had a family members where dad was away for work a lot, mom was there by herself, and if they don't have nursing, as we know, home nursing isn't always readily available in all regions, and they lived in a relatively rural environment, more in central Pennsylvania, that mom can't be awake for 3 or 4 days at a time. That's just not possible. So this family had a very large community and church community available to them, and many people were ready and willing to help. And many were a little concerned about taking on all of the fully trained duties, particularly, replacing the tracheostomy tube. But what we did is we trained a very large group of people and developed this watcher program where there were people who were trained up to a certain level to be there to help provide support for mom so that she could sleep, so that she could take a shower, so that she could go to the grocery store, or make dinner, do laundry, do those other things. But she's there as that fully trained person, and they're there helping to watch after the child, and they could get her if needed. So having that made it for the ability for this child to be able to go home, and did very well. And they continue to have their watcher community actually was more stable than their nursing schedule, which was wonderful. But we're able to do very well at home with that. And we have employed it with a couple other families since that first group that went through. So it's just one model to potentially be able to take a look at to make sure that there is someone around. For our fourth question, we discussed tracheoaspirates, and should tracheoaspirate cultures be obtained for infants and children with tracheostomies during routine clinic visits and acute respiratory illnesses. So that would be for both sick and well visits. We had 3 recommendations here. In well children with tracheostomy tubes, we suggest against routine surveillance of tracheoaspirates for bacterial growth. In children with tracheostomy tubes and concern for lower respiratory tract infections, we suggest culturing the tracheoaspirate when needed to guide management only. And in children with tracheostomy tubes who were recently treated with antibiotics and are clinically improving, we suggest against test of cure tracheoaspirates. So one of the things that was noticed amongst the pediatric pulmonology community is that people would get a lot of tracheoaspirates, really taking a look at biomarkers and really trying to predict microbiology during acute illnesses that would help them guide their antibiotic choices, knowing what the normal flora is for that child and what changes were. But that isn't a non-invasive process for the child. Some children really hate to be suctioned, and there could be complications with having prescribing antibiotics this way. So, and there's also costs related to it, doing these surveillance cultures when, what are we doing with them really, to really trying to slim down and minimize a number of procedures and testing and things that are being performed for a child that's already being picked and prodded and everything so much. So our fifth question was, when should infants and children who have tracheostomy tubes undergo an evaluation with a bronchoscopy, whether that be rigid or flexible bronchoscopy, to evaluate the airways? And there are 2 recommendations branching from this question. So that for children with tracheostomies, we suggest performing an endoscopic airway evaluation, and those with a change in symptoms or with persistent symptoms that are unresolved by other medical management, because we're looking to see if there's something else that was occurring down there that we haven't been able to predict and treat. And the second recommendations are for children with tracheostomies, we recommend performing a complete airway evaluation before a decannulation attempt. And we did define what an airway evaluation is to us, as it's potentially different depending on the provider and where people are. So that to us was an evaluation of the nose and nasopharynx, the oropharynx and oral cavity, the supraglottis and larynx, the subglottis, trachea, and bronchi. That all being performed prior to any sort of decannulation attempt. And if there are frequent occurrences with airway lesions, such as granulation tissue or any sort of supraglottic collapse or tracheal wall ulcerations, those are the things that we would be looking for if there are any persistent symptoms in between. And knowing that this procedure can be simple and done in the office, or depending on the child, may have the need for general anesthesia, depending on the airway location that you're looking at, or where you are in the world and what your region does. We wanted to make sure that we were only doing this during necessary times. And then our final question, the sixth question was, should all infants and children with tracheostomies undergo a capped polysomnography before decannulation? And our recommendation was that we suggest a polysomnography with a capped tracheostomy tube or occluded stoma in the following situations. If we're assessing transition readiness from invasive to non-invasive ventilation, unclear if capping the cause of failed capping trials, and for patients with medical and or airway complexity. It's noted that in the 2013 AEOH NS consensus statement on decannulation, there was not evidence-based, but expert panel, and it did not include the use of polysomnograms. So many centers use these for decannulation protocols. We actually found about 21 studies that examined the role of polysomnographies for decannulation. However, there were no randomized controlled trials, so the certainty of evidence was very low, but still is something that we recommended in these three situations. So in summary, these recommendations can be taken as they relate to individual practice and can be used to help put together processes in order at institutions for you to be able to have and get the support that you need if it's an organization that doesn't have, say, a standardized process in training and education before they go home, being able to furnish a clinical practice guideline from the ATS saying we should have one of these things can help get the resources that are necessary. So some of these things, we look at them and might say, of course, we should be doing that. But unless it's written down and published as a standard, it makes it hard for some institutions to really provide the resources in order to do that. So we hope that these guidance for these situations addressed will assist in some standardization of practices so that individuals going home with tracheostomies will get the same care everywhere. There are, of course, many more questions that we all had and that I'm sure many of you have some of the same or could add to that list as well that are not addressed here. But the plan is to, as the revision process continues cyclically, as it will for these, that we'll continue to add new questions to future iterations of the guidelines. And then we'll end up with a guideline with 12, 13, 14 questions because we just add on. We don't take any away generally. We definitely need a lot more research in the future. There are a lot of questions that we had that we may have put up to one of the six, but there wasn't any research to support doing a question and a review on those. So definitely, if there are questions that people have, I would definitely say, please do the research, even if it's something small. There's a lot of things that there is nothing out there for us to do guidance off of and to do a clinical practice guideline out there. So publish, publish, publish. Thank you.
Natalie, thank you so much for setting us up for the webinar by talking about the ATS guidelines, but also to other institutions who will look to these clinical practice guidelines for forming their own programs. Next, Lindsey Scheller is going to talk to us about infection management.
Great. Thanks so much, Michael. Hello, everyone. Very excited to talk to you today about reducing infections for children. Can we go ahead and start? So children with tracheostomies are at high risk for respiratory infections because the tube that they have bypasses the nose and mouth's natural germ filtering defenses. Respiratory infections can be bacterial or viral, involving the trachea, the bronchi, or lungs. Sometimes you'll hear your care team as tracheitis, bronchitis, or pneumonia. But why do we care about respiratory infections? Respiratory infections are the leading cause of hospitalizations for children with trachs, accounting for up to 75% of readmissions. Within the first year alone of discharge with a new tracheostomy, up to 48% of readmissions were due to tracheitis. Respiratory infection-related readmissions are disruptive for families, causing emotional and logistic strain, and can carry a substantial financial burden. With the US hospitalizations alone, it's estimated to exceed about $900 million annually. Therefore, prevention, early identification of risk factors, and diagnosis of pediatric tracheostomy-related infections is really essential to avoid severe complications. So current studies show higher risk among children who are younger, have multiple medical comorbidities, require mechanical ventilation or oxygen, have neuromuscular conditions or gastroesophageal reflux, receive corticosteroids or have Pseudomonas identified in their tracheostomy cultures. Many of these factors reflect underlying medical complexity, and while this information is helpful for clinicians to identify which children may benefit from closer monitoring, most of these risks aren't things families or care teams can easily change. The good news is that small but mighty actions, when taken together as a team, can make a meaningful difference in preventing infections. So next, we'll talk about practical team-based strategies to help prevent some infections. Great prevention strategies combine daily airway care, clean equipment practices, close monitoring, and strong communication between caregivers and healthcare providers. Infection rates can be reduced with standard infection control procedures like hand hygiene, personal protective equipment, and limiting contact with visitors who are sick, which I know if there's siblings at home, it makes it really difficult. Hand washing may seem simple, but during busy moments, it can sometimes be missed. Clinicians and caregivers should always wash their hands before suctioning, trachea, or handling equipment, since germs from our hands can easily be transferred into the airway. In hospital or long-term care settings, using personal protective equipment or PPE like gowns and gloves and masks should also be used based on the known infection to reduce the spread to other patients. Another key prevention strategy is consistent tracheostomy care. This includes cleaning the stoma site and changing the trach ties and dressing at least once daily, and sometimes more often depending upon the amount of secretions. Keeping the stoma clean, dry, and free of excess moisture is really important because that moisture can increase the risk of both infection and skin breakdown. And sometimes it's not just how often we change to dressing, it's which dressing we use. So really working with your wound care nurses to help tailor that dressing will really help your child. And because a local stoma infection can quickly progress to a respiratory infection, checking for early signs of infection during trach care like redness, swelling around the site, discolored drainage, and sometimes pain or tenderness is really important to note. Good oral hygiene, such as brushing your teeth twice daily, is also another really important strategy. Poor oral care has been associated with respiratory infections due to potential aspiration of bacteria from the mouth. Keeping the respiratory equipment clean is another important way families and clinicians can help prevent infections. At home, it's best to routinely clean equipment following the guidelines from your supply company. And in the hospital, ensuring there's established guidelines and workflows in place among respiratory therapists and nurses for routine cleaning schedules. This includes wiping down your ventilator surfaces, keeping a sterile and dedicated area where you place supplies for trach care or trach changes, and thinking about anytime water sits around, bacteria can grow. So your humidifiers and nebulizers can collect germs, which is why following your manufacturer's cleaning instructions is so important. So depending upon your nebulizer, you might have to rinse it with sterile water after each use and let it air dry to help reduce that bacterial growth. It's also important to regularly drain out and discard any water that builds up in your vent tubing, making sure it doesn't flow back to the child. And later in this webinar, Phillip will share some really great strategies they use at home to help reduce that rain out in the vent tubing. Managing secretions is also really important to prevent aspiration and infections. So staying on top of suctioning the trach, changing your dressings, helping control drooling, and also making sure that when you're changing those suction catheters, you do it based off manufacturing guidelines. So if it's a single-use open catheter, throwing that away after each use, and changing your closed suction systems, usually about once a week is recommended. And hospitals have also created some more innovative strategies to reduce infections like care bundles. So that includes elevating head of the bed, doing regular oral care, and also maintaining the trach cuff pressure. Even with the best prevention strategies, the reality is we can't avoid every infection. So early detection is important. Early changes in a child's condition are sometimes very subtle and specific to that child. Caregivers really know what's normal for their child. So centering families in early recognition is critical. Some things that we look for include secretion changes like color, volume, and thickness or smell, increasing suction needs, ventilator pressure alarms, or lack of tolerance, and also behavior changes. We as a team, both as clinicians and caregivers, should really be good about communicating these changes promptly. Families can also help by sharing their child's baseline appearance, typical suctioning or ventilator needs, and how their child usually presents when they're getting sick so the care team can act sooner. Strong partnership and communication may also include using standardized handoff tools. So important baseline and infection-related information follows the child across settings. Finally, supporting home health nurses with training and trach vent care. Early detection is really important. While a lot of times families are the ones doing this teaching, institutions can help too. For example, UC Davis actually encourages the home nurses to come to the hospital with a caregiver to receive some training. So Natalie did a great job touching upon one of these questions for ATS, their guideline that they did. And so this is specifically for tracheal aspirate cultures. And for those who don't know, a tracheal aspirate culture is a sample of secretions taken from the tracheostomy tube, sent to the lab and see what kind of bacteria grow. There's a ton of ongoing debate, and like Natalie talked about, there's not a ton of evidence here to help support us to make really firm decisions for cultures and treatments. But these cultures really do help us decide on antibiotics, and it could lead to overuse. So the current guidance, like she says that we should do or can recommend doing a tracheal aspirate if a child is having signs of lower respiratory tract infections, and we need to have some kind of guidance for managing with antibiotics. We don't usually recommend having cultures used for routine surveillance or when the patients are coming into the clinic for baseline. And also not recommended for test of cure cultures for children who are improving with antibiotics. And a test of cure culture is basically when a sample like a trach aspirate is collected after treatment to check for remaining bacteria. So what is the research behind these guidelines, and why do we want to be cognizant with the number of cultures we collect? Children with tracheostomies receive a ton of antibiotics. On average, they get about 4 courses per year, and that's almost 3 times compared to the general pediatric population. Unnecessary cultures, like Natalie said, can be really uncomfortable for children, but they also drive antibiotic overuse. They can build up antibiotic resistance, and it increases costs and family anxiety. Most children with tracheostomies are actually chronically colonized with bacteria. So and that's even with the type of bacteria that's most commonly seen during acute respiratory infections. This means that a positive culture doesn't automatically mean it's an infection, and it can often reflect what's living in the airway at baseline. Another issue with cultures is that they aren't consistent as screening tests, with one study demonstrating 24% sensitivity and 82% specificity, meaning that it did poorly in identifying infection when one is truly there and performed moderately in avoiding false alarms. When we think about the colonized bacteria that's already living there and the screening test issues, surveillance cultures may not reliably predict what's causing an acute illness. We also know from recent studies that the airway microbiome is highly dynamic after a new tracheostomy, especially in the first few months. Bacterial communities shift over time, which is why timing and clinical context matter when interpreting our culture results, especially if they're surveillance cultures. Even after respiratory infection, microbial diversity, meaning the balance of bacteria in the airway, can stay altered for weeks. This helps explain why tested culture results may remain positive even when a child is clinically getting better. So the key takeaway message here is to use cultures thoughtfully, guided by symptoms and clinical changes, and to treat the whole child and not just the culture results. So some of the clinical markers beyond the symptoms that we talked about earlier include radiographic findings consistent with pneumonia, elevated white blood cell counts, changes in respiratory effort or support, presence of polymorphonuclear cells on tracheal aspirate gram stains, and also considering possible viral testing to support antibiotic stewardship, since a lot of times the viral and bacteria presentations are very similar and hard to differentiate, but one of them doesn't require antibiotics. And I do want to recognize that while we are trying to be safer with our cultures and our antibiotics, we still want to use some of these cultures to continue moving research forward and to continue seeing how we can better improve cares. So in conclusion, reducing respiratory infections really depends on strong communication and collaboration between caregivers and clinicians to support early prevention, detection, and shared and open decision-making around tracheal cultures and treatments. Thank you.
Lindsey, thank you for that very apropos instruction on tracheal aspirates. Katie, your section's up next.
All right. Hello, everyone. Oh, I think the slides are backwards. These are Philip's. I can start talking from mine in the meantime. So I'm going to review some practical considerations on two of the recommendations that Natalie went through. One is on implementing standardized discharge processes for safe discharge to home. And the second is about how we prepare caregivers as one of those, ideally two, but at a minimum one caregiver on what they need to know prior to feeling comfortable sending them home. Some of these recommendations have some prior guidance from an ATS guideline for pediatric chronic home ventilation. So things we look for discharge are that the patient is stable, which is left kind of vague, but generally meaning no recent exacerbations or illnesses, and that we haven't been weaning anything too close to discharge. So we feel very comfortable that that transition can go smoothly. That the family, we've identified the caregivers, and I'll go through in a little more detail what we're really requesting that they are comfortable to do. That we have a DME company that's able to respond to technical challenges and supplies, and that we've checked that their home environment is safe and has some access to emergency care if they need it. In terms of learning objectives for families and professional caregivers, we're looking for them really to be able to go through a full pulmonary care assessment to diagnose the problem and then be able to respond to it, whether that's a tracheostomy tube replacement, suctioning, changes in the size, being able to do emergency responses as advanced as CPR, and have some plans in place for practical problems like power outages at home, and to feel really comfortable in knowing what each part of the equipment is for, and what the medications are used for. It's really important that these skills are learned completely and that the family is comfortable before going home to prevent additional morbidity and mortality for these kids. Having a tracheostomy and a home ventilator already creates a lot of risk, both from the underlying conditions that require the support, but as Lindsey was going through, infections and other emergencies can be very dangerous. In the first year after being discharged, up to 75% of children will have some unplanned rehospitalization. And within the first 2 years of having a trach placed, roughly half of children will have multiple visits to either the emergency department or fully readmitted. Many of these can be prevented by more comfortable management at home. And ultimately, the biggest thing we worry about are preventable deaths that can happen in almost 30% of children as a result of an improper emergency response. This can be from just it's not detected in time, that the equipment fails to pick up an issue or to alert anyone, which happens more frequently in our smaller kids with smaller tubes. And just the risk of obstruction is bigger in those patients.
Excuse me, Katie, we just got your slides again. Amy is going to share them.
Oh, okay, thank you. So what are the core things that we want to address prior to discharge? I'm going to go through two main categories quickly. One is caregiver education, and the second is on community education. So we've gone through what are we asking families to know before going home, but how do we get them comfortable to be able to do that? For adult learners, just having written materials or passive videos is not sufficient for having people comfortable in what they need to do. And we really encourage practice with simulations on their own home equipment. We know from just anecdotal evidence, but also a huge amount of research that training for medical residents, that simulation is a highly effective way of enhancing skill acquisition, reducing errors, and allowing an opportunity to practice without causing real harm. Part of the success of this is that you have immediate feedback, and that practice over time does make residents much better at real life emergencies as well. We expect the same for caregivers, that with adult learning, hands-on style is really the best. And the resources in the ICU are not going to be the resources that they have available to them at home. So we really want them to be familiar with what their equipment and their resources are going to be, and to give opportunities for correction through direct observation, and really make sure that families are comfortable with what they're being asked to do before they go home. In many cases, they're also going to be asked to train their home nursing staff if they're lucky enough to do it, because we have a huge shortage of especially pediatric trained nurses that are comfortable with trach and vent management. I want to take a moment to pause and remind ourselves that while we're using similar models as we use to train healthcare providers, we are asking families to do something that we try not to do for ourselves, which is caring for our own family. And they don't have the benefit of coming off shift. So we really want to keep in mind the trauma that comes from interacting with the hospital, especially the ICU, but also the challenges of being at home and dealing with the unplanned admissions, the changes in their child's condition, the progression of disease. And then the further frustration that even when they're very comfortable with the care, that often they're communicating to medical providers what they know, that they're coming places where not everyone is as comfortable as they are. This puts a lot of pressure on families. So how do we support them in the community when we send them home? Aside from having a primary care doctor and ideally a medical home, we would really like the home care services, the local emergency response, and the school-based services to be as comfortable as they are. What we're finding, though, is for pediatric patients with complex medical needs, especially with technology dependence, such as tracheostomy, almost all of the care happens in a small percentage of very high capability centers that are not always very close to the families. And they often will drive past multiple other centers to get there and have to train their own local EMS if they need to be involved. The home nursing shortage is just a small drop in the bucket of the general pediatric nursing shortage. But this also adds a lot of stress that there's not support at home. And many of these nurses are planning to retire or are just starting and don't have the relevant experience. This shortage is even worse in rural areas, but we don't have a lot of support in the community for all families that we send home, aside from the 1 to 2 caregivers that we're training. So thinking ahead as we have these guidelines that give us sort of our goals and our direction, but really starting to standardize the inpatient teams to have resources and a curriculum on what materials we want to feel that we can train caregivers to be comfortable at home, to have ways of evaluating comfort and competence for the routine and emergency cares for caregivers and for healthcare professionals in the community that we're trying to train on these skills, and being able to build the programs to certify people to do this. And finally, to really advocate for the services that families need to make sure that they can still exist in their community and not become isolated with the burden of this care.
Katie, thank you so much for talking about the considerations that we as healthcare providers have to make for these complex families, which will segue very nicely to you, Phillip.
Thank you, Michael. So in reflection of what we thought were the great things about transitioning home, were access to an RT, and not just an RT that is through the home health network. They're there really just to set up equipment, and they're stretched super thin. But we were lucky enough to have access to someone who would help us with illnesses. We have 3 kids, and our youngest was on the ventilator, and so we had lots of illnesses constantly. And also, when she first came home, it was tough even to differentiate between, is it are these signs a drug wean? Are they a change in what her needs are as ventilation? Is it illness? And we're lucky enough to have a really great RT, Michael, I'm going to call you out, sorry, to help us out constantly. Do we need to go into the doctor? Do we need to take the hour and 15 minutes that it takes to pack up all of our equipment into the van to drive to go? Or is it something we just weather at home and make adjustments? Another thing that we thought were really important is when we traveled. We were one of Michael's graduates of the home training program, and trying to think about, when we get to the destination, what are we going to need? We had all of the emergencies that we were trained for, we needed. And one of those emergencies needed an emergency trach change. I think 3 months, not quite 3 months after being home, right on the floor of a hotel lobby. She plugged in and needed to very, very quickly. And that was incredibly scary. And even with all of the training, I 100% relied on my wife to take charge and stay calm. I'm so lucky and thankful that she's a former NICU PICU nurse, and she took the lead. Obviously, me helping, but if it was entirely on me, I think it would have been a whole lot more scarier. But traveling in from then, the reason she needed a emergency trach change is she was starting to catch a cold, and we didn't recognize it, and it happened very quickly. And Michael was able to guide us through, could we even drive the hour and a half home safely with her being sick and as ill as she was. Another thing is, we luckily at the University of Virginia, which is closest to us, we have a complex care team, but the primary care physician was great, but we were fortunate enough to get pulled in with someone else, which made a tremendous difference for us. Being associated with UVA, she had constant training, and there was a big difference between someone who had continued training and access to answer questions quickly with messaging and connecting with the people that she knew all throughout the hospital and specializations. Also, her learning, every patient is different. Ava, she was afebrile. She didn't have fevers with infection, any of her infections. She fevered once in a while, but she's had pneumonia 4 times, lots of recurrent trach infections, and recognizing that and not waiting until she got so bad that she had to be hospitalized. It took a couple of those, and then after that, She recognized that we just can't wait for antibiotics or next treatment. Another thing that was hard was building trust with the family from pulmonology and ENT. My wife is a former PICU nurse. She's an NP now. And it's like the best case scenario for a parent. Unfortunately, I stayed home and I did my best, but I always still relied on her. And even with my wife's experience, it was hard to get antibiotics. The first 4 months at home, I slept on the living room floor and slept in 30-minute increments because she needed suction constantly. And all the while, it was just because of a low-lying infection. Finally, after I think maybe third or fourth visit, my wife was able to convince to get some antibiotics. 24 hours later, we slept for the first time, which was like life-changing for us to actually sleep. You kind of go crazy without sleep, which I'm sure all you doctors know. These are some of the things that we kind of engineer at home and adapted from things that we found. So one of them, granulation tissue is always an issue, I know. My mom helped us sew up and make these straps that went around Ava, our daughter, to keep the tubing from flip-flopping around because it moves, and that would twist and gag and make her cause emesis, and also that constant movement, creates granulation tissue. So my mom helps us figure out, make it Velcro so that as she grew, that strapping could change with her size. In terms of reducing alarms, disconnections, that kind of thing, we found that a strap connected to her as she became mobile was super helpful. But probably the best thing, because as a parent that has to be available at any moment's notice, we sewed up a fleece sleeve for the tubing, and instead of the rain out collecting in a low-lying component and having to remove that, which causes alarms, we went from waking up every 3 to 4 hours to every 6 to 8 hours. So that was a huge thing, just keeping that tubing warm so the condensation went both ways to the patient and all the way out of the machine, which didn't cause any issues there. And then we had to figure out things to not lose equipment and make things work for Ava, because you get very little equipment at home as compared to the hospital. And when we finally got a speaking valve, a tracheal speaking valve for her, Ava didn't like it, obviously, and threw it immediately. And I spent days looking. We finally found it, but I learned my lesson. We had to not lose that stuff. Once you become mobile, there's a lots of rolling equipment we found was awesome. One of the things is being mobile throughout our home, heavy duty extension cord where we can move all of the stuff. So she was always a part of the family. We researched on YouTube as much as possible and through different Facebook groups, but it seemed like all of the patients were just in one room. And our goal was to give her a normal upbringing as much as possible, to develop her brain as much as possible to a normal kid. So we wanted her mobile as possible. We eventually put her ventilator inside of a wagon so she could walk around, enjoy life, move, and be much more autonomous. And then once she started crawling and walking, there's a little picture you can see. We just took the strap or the mobile ventilator, which had straps. We put Velcro on so that way Ava could drag it around and it would pull on her clothing with another strap. That way she could just roam around the house and wherever. So that was a big quality of life, not necessarily preventing infections, but it was great for us. And we have a happy story. Ava is continuing to grow and do awesome, still fights pneumonia and all that, but she has been decannulated.
Thank you so much.
Yep, sorry.
Sorry, do you want to continue?
I was just going to say, like, we are so thankful to have a program that really did train us for going home, because all of the emergency, you think like, oh, that's not going to be me. We used all of them, like emergency trach change, like trying to problem solve equipment. The very first night we came home with one ventilator, and we had to reprogram it 3 times in the middle of the night while my wife handbagged our daughter. So very thankful for a good education program to go home. Thank you.
Thank you, Philip. That was a really amazing talk, and it's great to see those innovations that you've got with all the mobility equipment. I'd like to thank all of the panel members for their really insightful talks today. We've got time just for a couple of questions here. One of them is, do you suggest to change tracheostomy tube before doing culture? And if so, what guideline would you use?
I can start, and then Natalie can probably chime in too, since she was part of the ATS guidelines. There's not any actually established guidelines from what I'm aware of about changing the tracheostomy prior to cultures. I think when we think of also trying to do the least invasive for children's trach changes is a really big procedure for them to have to go through. So doing that just for a culture may not justify getting a quote unquote cleaner culture result because of that biofilm or that chronically colonized part that we were concerned about. I have seen a study that's published trying to decrease the number of cultures that or number of antibiotics and cultures that they do. And one of the ways they did it was by changing the tracheostomy whole tube. But that's fairly invasive to be doing that frequently if we're trying to capture cultures. So yeah, there's not any standardized guideline for that. Natalie, I don't know, or Michael, if you had any opinions from the respiratory side.
As far as the ATS guidelines go, we didn't speak to that in that question. There are times when for our patients in the ICU, when the docs want to get a culture for whatever reason, we'll time it with our already weekly scheduled trach change to do the culture right after with the fresh trach. So, but usually if we're needing to do it for an illness or whatnot, I'm not certain how much it would matter because you already have it all up in there.
Thank you. We can probably do one more question as we're running out of time. What are the earliest signs of respiratory decline that are commonly missed in home settings? Anyone on the panel like to answer that one?
Maybe I can chime in a little bit here. So I think when we're caring for someone with a tracheostomy, if their resting respiratory rate starts increasing and you see that there is some visible airway distress signs, that could be a clue that something is impending and you want to kind of act on it. The other one is often dismissed as anxiety or overexertion and not really correlating that to something impending. So increased workup breathing without obvious distress, like mild use of accessory muscle, slight nasal flaring, abdominal breathing, or shallow rapid breaths, and also change in voice, speech or sound. And instead of being able, if they're able to use a speaking valve, or if they're able to phonate around the tracheostomy tube, if they're typically speaking in full sentences, but they're able to speak only shorter sentences, or their voice is quieter, or new, hoarse, or wet sounds are all clues that there is something not right. We really need to assess to figure out what's causing the problem and not just dismiss them.
Thank you so much, Vinciya. Katie?
In some of our patients that are weaker, so that have this support for neuromuscular weakness, for example, they may not be able to increase their work of breathing, but increased fatigue or agitation and just kind of off in alertness from their baseline can be a sign of respiratory decline also. So knowing what their patient's baseline is can really help us in picking up on the earlier, more subtle signs that something is brewing in terms of infection or respiratory issues.
Thank you so much.
I'd also love to just jump in and add that Phillip made a great point that, Ava didn't classically show fever or other signs like that. And that's why those smaller cues of they're napping more than usual. And when parents say that or their bedside nurses say that, they're things to listen to and kind of also help decide treatment.
Yeah, they're really important points to listen to, aren't they? I agree. Okay, thank you, everybody. We'll just finish up there. Our next webinar will be on May the 6th at 5 p.m. Eastern Time. So hopefully we can get people to come and join us, exploring topics that shape safe, collaborative tracheostomy care across the globe. This is our site. If you want to access any more training or resources, you can log on to our website here. And we also have a tracheostomy journal, and we're currently accepting submissions for this journal. Also like to give a shout out to our industry partner, Medtronic, who supports our webinar. And again, thank you very much, everyone.